Thank you so much for having me here. We appreciate this opportunity. And so I want to talk to you about quantitative EMG. Um, so we all know that when we do EMG, we look for certain piece of information that can help us diagnose the patient. And so EMG can tell us whether it's axonal or demyelinating. It can tell you how severe the problem is, whether it's active, chronic, or active and chronic. And it can tell you also whether a certain muscle will be suitable for biopsy. Now, there's many different types of EMGs that have been developed over time. So the first line is the conventional needle EMG that you all do. And they give you interpretation of signals from muscle. And the drawback is fairly subjective. It's basically how you interpret the signal. And if you do this a long time, you can sort of tell. But if you starting out, sometimes it's hard to tell normal from mildly neuropathic or mildly myopathic. Macro single fiber EMG is done pretty much to look for evidence of neuromuscular transmission. And it's pretty sensitive, but not really particularly specific. Macro EMG, we don't do much anymore. It basically tells you the information about the whole motor units. Scanning and surface EMG sort of fell out of favor because it doesn't really give you any additional information. Quantitative EMG is that's why we're here today. And basically it gives you that objective measures that you often is helpful to decide whether it's myopathic or normal or neuropathic. And it basically use statistical and probabilistic techniques to allow for greater objectivity. So you can see here, okay. So you can see here on the left side here is what a motor unit may look like. So you have the cell body, the neuron, and it has axons that connect to different muscle fibers. Now, if you happen to cut off those axons, like happened here, this cell will die. But in the next 3 months or so, the adjacent motor unit's motor neuron is gonna send out axons in this process of reinnervation that connect these muscle fibers together again. So you can see that on this side, when you do EMG, you see this typical triphasic waveform, and that's what normal looks like. But when this motor unit acquire additional muscle fibers, its territory now become a lot larger. And when you stick a needle in, you're going to see this large units with long duration and polyphagia. Third situation is when you have myopathic process where you start losing muscle fibers. So when you summate the muscle activity of the remaining motor units, you're going to have a potential that's much smaller and shorter, but they can still be polyphasic. So basically, that's how you can tell whether something is normal, neuropathic, or myopathic. So this is where quantitative EMG comes in. It's been around for a while. It was first introduced in the 1940s. And back then, they have oscilloscopes. So what they do is they take pictures or tracing of the oscilloscope, go home at night and measure it out and calculate to see what normal, what's the duration and amplitude is. Now, with the advent of computer back in the 1970s, we can sort of identify the motor units and have the computer actually do that measurement so you don't spend the whole night doing this. And then since then, people have come up with different automated programs, including decomposition techniques to sort of measure the potentials easily. If you do quantitative EMG, you're looking at you're going to spend an hour doing a muscle. So with the decomposition program, that's accomplished in a few minutes. And okay. And as a result, it's easier. The problem is that it costs a lot of money, and none of us have the thousands of dollars to spend on it. So it's really not widely available. So let me show you an example. So is there a way to so basically, this is an EMG of the left bicep in a 33-year-old man with proximal muscle weakness. And you can see the potential right there. Here we go. So we can trigger the potential, and I'm triggering the this units right there, and then take out and measure the duration. And you can see that in this example, the duration is 6 milliseconds. So we know that for a 35-year-old person, the normal mean potential duration for bicep is 10.9, and we consider abnormality 20% above or below. So if it's 13, which is 20% above, and the duration is more than 13, you know it's neuropathic. If you have 8.7 or below, then it will qualify as myopathic. And the absolute range is anywhere between 120 to 390, and that potential, I don't know if I can tell, that potential is 106. So it falls in the low range of normal there. So that would make me think that this is myopathic. Now, that's only one motor unit. To do this correctly, you actually have to collect 20 and average them out. So why do you, like I said, it takes about an hour to do a muscle, so it's actually pretty time consuming, and it takes a lot of patience as well. So why would you want to do this? Well, it gives you a more precise interpretation of findings. It can minimize observer bias. So if you examine somebody and you think that this patient is going to have a myopathic process, you may sort of, start to select the smaller one to make sure that it fits with your interpretation. So that's something you need to wonder about too. But at the same time, if you don't know what you're looking at, you may not think that it's myopathic. Because you can actually measure duration and amplitude. You actually have a number to track over time. So it's a way for you to measure progression. And it's useful in early or mild neuromuscular disease when the finding is subtle, and you can pick that up. Potential drawback, it requires normal values. And at the end of this presentation, there's a couple tables of them. I will make this presentation available to Dr. Tung, so you can post it online so you can get those values. Now, when you recruit a muscle, you recruit the smallest motor units first. It's the size principle. So you recruit, if you want to move your fingers, you need to recruit all the muscle that affect that finger. And so the smallest motor unit is going to start to fire. And then the next bigger one, next bigger one, next bigger one. So it's very important that you do the first motor units, because it doesn't make any sense if you start averaging the 4th and 5th motor units, because they become sort of large and it will be non-informational. And also that the values that I'm going to give you, look at the first recruited units. So anything beyond that, it doesn't apply. How good is this technique? Well, a friend of mine, Tom Brannigan, did this study in '97 in inclusion body situs. And unfortunately, he looked at 20 patients, but not all of them have quantitative and not all of them have regular EMG, believe it or not. But if you look at the patients who have quantitative EMG done, 13 out of 20, 13 out of 20, we were able to find myogenic disorder in almost all of them. If you look at the conventional qualitative EMG that was done in 8 out of 20 patients in that series, only one of them show up as myogenic, 4 of them actually show up as neurogenic, and 3 non-diagnostic. So his conclusion was that quantitative EMG is necessary to accurately characterize the myogenic motor unit morphology in some cases of IBM. there are other study as well. So in Neurological study in 2011, the predictive value of QMG was 87.5 to 100%, which is pretty good. And he thought amplitude was the most sensitive measure of myopathic abnormalities. And of course, it's sensitive, but it's not specific. So if you have a myopathic process, it's going to be abnormal, but you can't tell which of the myopathies this is going to be. And Fredrickson found pretty much the same thing, where high sensitivity, but really low specificity in terms of the actual myopathy underneath. Smith did this in children, and as we suspect, abnormalities were found in muscular dystrophy of polymyositis, but in patients with congenital myopathy and metabolic myopathy, the result was pretty much normal. To do EMG, QMG, so you need to measure at least 20 motor units with a peak-to-peak amplitude of more than 50 microvolts, so that way you don't, accidentally measure fibrillation and positive shock waves. The rise time had to be less than 0.5 millisecond, and the reason for that will be apparent in a second, and it has to be the first recruited units. So the reason why we want the rise time to be 0.5 milliseconds or less is because the amplitude depends on how far you are away from the motor units. If your rise time is 0.5 millisecond or less, you're right on top of the motor units, and therefore it's an accurate amplitude measurement. Obviously, the farther you away from the motor units, the lower the amplitude, and so that would not be an accurate assessment. Duration is actually less of a sensitive measure in terms of rise time. The rise time doesn't change the duration very much. And duration, of course, is measured from deviation from baseline and return to baseline. To distinguish that from a turn, which is deviation from change in direction of potential but did not cross the baseline. We'll talk about phases. We also measure that, and I just talked about turn. So the table here is for normal values of different muscle and ages, and you can see that as you grow older, your duration increase and your amplitude pretty much remains the same. And here is for the facial muscles, and you can see the name of the muscle across the board. The references at least at the bottom, and here are the references. And here's the neck and shoulder and back muscles. And here is the arm and hand muscle. And again, the muscles are listed across the top, the reference across the bottom. You can see the as you grow older, your duration increase. I'm looking at something for other reasons. Okay. And here's the legs and foot muscle. And here the amplitudes average. Amplitude is actually tricky because we know that they're between roughly 200 to 400 microvolts, but we don't have a cutoff of where abnormality is. So obviously, if a potential is more than 1 millivolts, that's clearly neuropathic. But if it's like 120, is that the cutoff? And we actually don't have that. So duration is what I normally use. Okay, so that's the end of the presentation, but I think we have a patient where we can actually examine a little bit later right now.